welcome to the Deep Dive. Today we're tackling a really fascinating neurological sign, the Argyll-Robertson pupil.
Mm-hmm.
Think of it like a key sort of unlocking understanding of some important conditions.
Absolutely. It's a classic for a reason.
We've got these revision notes packed with info, and our mission really is to pull out the crucial bits, help you get it fast.
Yeah, make it stick. Once you grasp the core features, it really does click into place.
Okay, so let's start there. What exactly is an Argyll-Robertson pupil? What are we actually looking at?
Okay, so essentially you're looking at both pupils bilateral, they're small, and often a bit irregular in shape.
Small and irregular.
Right. But the real kicker, the thing that defines it, is how they react. Or rather, how they don't react well to light.
Ah, okay, so shine a light.
And there's very little, or maybe no constriction, poor reaction. But then you ask the person to focus on something close, like their own finger moving towards their nose accommodation. And the pupils do constrict. They react normally to focusing.
So light reflex is poor or absent, but the focusing, the accommodation reflex, is fine.
Exactly. There's a useful mnemonic, ARP, accommodation reflex.
Yes, pupillary reflex absent, ARP. Got it.
Precisely. It's a classic pupillary syndrome, points towards certain neurological or ophthalmological issues.
Right. And what's the number one condition, the big association we need to think of with ARP?
Neurosyphilis. That's the big one. Late-stage syphilis affecting the nervous system. The link is really strong.
Okay, neurosyphilis is top of the list.
Mm-hmm.
Are there other possibilities, maybe less common things?
Yes, definitely less common, but good to be aware of. Things like diabetic neuropathy can sometimes cause it.
Right.
Also, alcoholic midbrain degeneration. Parinaud syndrome, often linked to pineal gland tumors pressing on the midbrain.
Right, the dorsal midbrain.
Exactly. And then even rarer causes like encephalitis, amyloidosis, MS, or other midbrain tumors. But neurosyphilis is the main association by far.
So thinking about risk factors then, it really comes down to
a history of syphilis infection, especially if it wasn't treated or wasn't treated adequately back when it was diagnosed. That's the key risk.
Okay, let's get into the why a bit, the pathophysiology.
Yeah.
What's actually going wrong in the brain to cause this weird split between light and near reaction?
Yeah, it's fascinating. The damage is thought to be in the midbrain, specifically the protectal area.
Protectal area.
This area is basically a crucial relay station for the pupillary light reflex pathway. Light hits the retina, signal goes back, crosses over in the protectal area, tells the pupils to constrict.
Right.
But if that area is damaged, that light signal gets interrupted.
So the message doesn't get through properly for the light reflex.
Exactly. But the pathway for the near reflex for accommodation, that seems to take a slightly different route or is just spared by the damage in that specific location.
So same general area, but different circuits, kind of.
Sort of, yeah. It's a neat demonstration of how specific brain pathways can be. This localized damage just takes out one function while leaving a related one intact.
That makes sense. Now, if we see small irregular pupils, we shouldn't just jump straight to ARP, right? Are there other things to consider? Differentials?
Oh, definitely. You need to rule out other causes of small or irregular pupils, like 80s tonic people, that's another one.
Okay.
Drug-induced meiosis, very important. Think about opioids, for example. They cause pinpoint pupils.
Right. Check the drug history.
Absolutely. And Horner's syndrome, too, though that usually has other signs like ptosis, the droopy eyelid, and anhidrosis, lack of sweating.
Good point. So how often do we actually see Argyll-Robertson pupil now? Is it common?
It's relatively rare these days, especially here in the UK. You're most likely to encounter it in someone with that history of neurosyphilis.
And neurosyphilis itself is less common now.
Yes, thankfully. Much better diagnosis and treatment for syphilis means we see fewer cases progressing to the late neurosyphilis stage. So ARP prevalence has dropped accordingly.
Okay. So recapping the clinical picture, if we're examining a patient, we're looking for
those key features. Bilateral, so both eyes. Small pupils. Irregularly shaped pupils. Poor or no reaction to light. But crucially, a normal constriction when they accommodate, when they focus on something near.
and maybe other neurological signs depending on the cause.
Potentially, yes. Depending on what's underlying it, you might find other neurological deficits or even other eye abnormalities.
So how do we confirm it? What investigations are needed?
Well, it starts with a really good history, asking about syphilis risk factors, and a thorough eye exam, specifically checking those pupil reflexes.
The light and near response.
Exactly. Then you move to investigating the cause. The key test is serology for syphilis blood tests.
So check for syphilis antibodies.
Yes, and if you suspect something else or need to rule out other neurological causes like a tumor, then imaging like an MRI scan might be needed.
And management. What do we do once we've diagnosed it?
Management is all about treating the underlying cause. You don't treat the pupil sign itself, you treat what's causing it.
So if it is neurosyphilis,
Then the treatment is antibiotics. Usually, high-dose penicillin is the standard of care for neurosyphilis. And of course, managing any associated complications.
what's the outlook, the prognosis for someone with ARP?
It really hinges on that underlying cause. If it's neurosyphilis caught reasonably early and treated properly with penicillin, you can often slow or halt the progression of the disease.
So early treatment helps.
Definitely. But if the underlying condition is advanced, or perhaps it's something like a tumor that's difficult to treat, then the prognosis might be less favorable.
And what about complications? Does the ARP itself cause problems?
That's an interesting point. The pupil abnormality itself doesn't really cause complications directly. The issues come from the underlying disease process.
So the neurosyphilis or the diabetes or whatever else it might be.
Precisely. Those conditions can lead to things like cognitive impairment, other neurological problems, visual issues beyond the pupil itself. It really underscores why finding and treating the root cause is so critical.
Okay, so wrapping this up, the big takeaway. Argyll Robertson pupil. Those small, irregular pupils, bad with light, good with near focus, is a really significant neurological sign.
And strongly linked, classically linked with neurosyphilis. That dissociation between the light and near reflexes is the absolute key.
Spotting it is crucial. A great sign to know for clinical practice and, of course, for exams like the MSRA.
Absolutely.
And if this deep dive has been helpful for your revision, definitely check out pastmsra.com.
And freemsra.com too, loads of great resources there.
So that brings us to the end of this deep dive. Here's a thought to leave you with. What other seemingly small, specific clinical signs can act as powerful clues, unlocking insights into much bigger systemic conditions?
Good question to ponder.